A global analysis of stroke incidence has found that in some countries, 1 in 3 people will suffer from a stroke at some time in their lives. It's an extraordinary number, and even in Australia, 1 in 5 of us will have a stroke during our lifetime. These statistics will surprise many and could overturn 20 years of teaching GPs and other doctors how to assess a person's risk of having a stroke. The person who led the study was Greg Roth, a cardiologist at the University of Washington's Institute for Health Metrics and Evaluation in Seattle. I spoke to him last week while he was on call at his hospital.
Pleasure to be with you.
These figures seem extraordinary. So what we're talking about here, I just want to be clear, what we're talking about here is not your risk over the next 5 or 10 years of having a stroke, but your lifetime risk of having a stroke.
That's exactly right. We know that the behaviors and lifestyle choices and medical care that people receive over the course of many, many decades piles up and drives a risk of stroke. And so we really wanted to capture that perspective of looking at the whole life course.
Now, this is the Global Burden of Disease study, which we've covered many times over many years. So before we go any further, what's the degree of reliability in the statistics we're about to talk about?
The statistics are quite reliable.
So give us a sense then globally of what the lifetime risk is, because the average was about 1 in 4, 25% risk, which is extraordinary. But some countries were even higher than that at 1 in 3 people.
The range is stunningly broad, and that was one of the things that was really surprising to us. We were able to combine all of the world's available data on either dying from strokes or having a stroke and surviving afterwards. And we found that in some locations, the lifetime risk might only be 1 in 10. And at the very high end, we found that it could be as high as 30 or even 40%.
Well, let's be parochial and talk about Australia and North America.
The risk in Australia is actually lower than the risk in North America. In Australia, we see risks somewhere around 20%, and that's on average for the population. But we know there are certainly high-risk populations within Australia where we would expect that risk to be even higher. But on average for Australia, we saw 1 in 5 people having a chance of a stroke in their life. In the United States, it was about 5-6% higher than that.
And some European countries were quite high.
That's right. The risk of stroke in places like Spain and France looked a lot like Australia. But as you headed east, we found a rising gradient and a larger lifetime risk of stroke. And some of the countries in Eastern Europe actually have among the highest risks of stroke in the world.
And yet some disadvantaged populations, such as Sub-Saharan Africa, are down at 1 in 10. Why is that?
Yeah, disease patterns in Sub-Saharan Africa are really different than the rest of the world. For example, individuals in that part of the world face burdens related to HIV and malaria and tuberculosis. The other thing is when we start looking at the risk factors for stroke, like high blood pressure, high cholesterol, we find that those are actually remarkably high in Sub-Saharan Africa as well, which is, I think, something that most people don't realize. And so the question is, if they've got all those high risk factors, how come they're not having high risks of stroke? And I think what we found in this study pretty convincingly is that the reason is that stroke really only starts occurring after age 40 and then ramps up very quickly as people age into their 60s and 70s. And people die at a much younger age of other causes in Sub-Saharan Africa. And so what we were able to show is that if you were to treat these other conditions that kill people at much younger ages, then we should expect a rapid rise in stroke in Sub-Saharan Africa as those countries begin to develop faster and faster.
What are the features of the Chinese population, Eastern European populations that give you a much higher risk of stroke?
That is maybe the most important question of all. And the first message I want to be really clear about is that it appears that the dominant risks of stroke are the same everywhere. High blood pressure, high cholesterol, tobacco smoking, physical inactivity, diabetes, and poor diet without enough fresh fruits and vegetables, nuts and seeds, and lean proteins and fish. Those are the things that are driving the vast majority of stroke everywhere in the world. But we do see that there are some risk factors that are much bigger contributors in particular places. And one of the ones that doesn't get mentioned enough is alcohol, especially in parts of Eastern Europe, really dangerous patterns of binge alcohol use. And that in and of itself is strongly associated with stroke. In China, I don't think we really know why there's so many more strokes in China, and for that matter, Japan, than other parts of the world. But we do see relatively high blood pressure there, and there may be aspects of dietary choice, including the amount of sodium in the diet.
Salt.
That could be a big, yeah, that's right.
And I should have asked this question earlier. There's 2 kinds of stroke. There's one where it's a blood clot blocking the artery, which is the commonest kind of stroke in places like North America and Australia and Europe. And then there's hemorrhagic stroke, which is the dominant stroke type in Japan. When you divide the stroke into causes, a hemorrhage rather than a blood clot, does the picture look any different?
Actually, even in places like Japan now, we actually see far more ischemic strokes than hemorrhagic strokes. But there certainly is a predominance of hemorrhagic strokes at younger ages and in places where there's less access to healthcare. I mean, we found that the lifetime risk of ischemic stroke is much higher, and it runs somewhere around 18 to 20% on average compared to about 7 or 8% on average for hemorrhagic stroke. But the important message here is that all of those risks that I described, those things that we know how to modify, those choices that people can make in terms of addressing, high blood pressure, high cholesterol, good diet choices, avoiding tobacco, those are drivers of both ischemic and hemorrhagic stroke. So I think the public health message here is the same, which is we know how to eliminate probably 80% of the cause of stroke, and it's going to bring down both those ischemic and those hemorrhagic strokes.
Having said that, though, general practitioners in the United States, in Canada, in Australia, in Britain, and many European countries are told, well, you don't just treat high blood pressure or you don't just treat high cholesterol, you actually assess a person's total risk of their chances of a heart attack or stroke over the next 5 years or 10 years. And countries set different levels, but it's usually around about 10%, maybe 15% risk the next 5 or 10 years. But they don't actually calculate a lifetime risk where you're just slowly acquiring the risk, the arteries are slowly blocking up. I mean, is this a bonanza for the pharmaceutical industry where you say, well, in fact, from the day you're born, it's a 25% risk. We should be putting blood pressure pills and cholesterol-lowering pills in the water supply?
No, I don't think it's a bonanza for the pharmaceutical industry. I think that there are many things that you can do to modify your risk of stroke and, for that matter, heart attacks that are not just taking medications. In fact, the earlier in life you start to focus on living in a way that reduces your cardiovascular risks, the less likely you are to need medications long term. So I think, what we need to do is take a step back, and it may not mean that you want to use our risk score to decide if you should take medications or not, but it does mean that the idea that we only start assessing people's risk at, let's say, age 40, and then we only look out 5 or 10 years is not helping us take that big picture, long view. What we really want to help people do are really simple things like, let's say, maintain a healthy normal weight throughout the course of their life. We know that if you can maintain a healthy weight as you go through middle age, that you are going to be at much lower risk of having these kinds of diseases like strokes and heart attacks. And so we have to go much earlier in life. We need to think about how we're educating kids in schools, how we're making healthy food available, how we're making workplaces healthy environments where people can get physical activity. We really need to focus more on that message of what I call primordial prevention. The things that you can do that underlie the development of the risks.
Greg Roth, I can hear your pager going off for people in Seattle who've clearly not necessarily prevented their heart disease well enough, and they're calling you for urgent cardiac care. So we'll let you get back to your patients. Thank you very much for joining us.
I appreciate the chance to talk with you, and am hopeful that this kind of work really helps people make better choices.